That's right.
Well, I hope it helps. Exactly.
Pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Welcome to the June 12, 2024 regular meeting of the Washington Township Healthcare District Board of Directors. Public notice for this meeting has been posted appropriately in our website. Tonight's meeting is in person and also accessible by Zoom. I ask that you please mute your system until such time as you need to speak. We are recording tonight's regular session of the board meeting. It will be posted on our website for future viewing. Shirley, please, roll call.
Director Epen?
Present.
Director Wallace?
Present.
Director Nicholson?
Present.
Director Yee?
Present.
And Director Stewart?
Present.
Thank you.
Moving on to oral communications, members of the public are invited to speak during the oral communications. When prompted, please state your name for the record, then proceed with your statement not to exceed 3 minutes. On issues or concerns not on the agenda and within the subject matter of the jurisdiction of the board. Are there any members of the public who would like to speak at this meeting? None? Shirley, are there any written communications?
No written communications.
Thanks. Moving on to the consent calendar. The consent calendar consists of those agenda items that the board will approve with one motion unless either a member of the board or a member of the public requests to remove an agenda item from the consent calendar. If any items are removed from the consent calendar, the board will take action on the removed agenda item later in the meeting under the action item heading of the agenda. Does anyone on the board want to remove an agenda item from the consent calendar? Does any member of the public want to remove any agenda item from the consent calendar? Being none, may I have a motion to approve the consent calendar items A through C? Director Wallace.
Yes, I move that the Board of Directors approve the consent calendar items A through C.
Second.
Director Epen?
Aye.
Director Wallace?
Aye.
Director Nicholson?
Aye.
Director Yee?
Aye.
And Director Stewart?
Aye.
Thank you.
Move on to the reports.
All right, we are going to start with Dr. Mark Saleh for the Chief of Staff report. Let's see. Is he on yet?
He's not on.
Yeah, I don't either. Why don't we go on? I see Sheila, VJ, so why don't we move on
Right,
to our Service League President then?
That was too quick. I think Dr. Saleh wasn't ready for that. That's the first time we have gone directly into
There he is.
Oh, there he is.
He's here. Okay.
Dr. Saleh, do you want a minute and we can have Sheila do her report, or are you ready to go for yours?
I would need a couple of minutes, actually. Yeah, so if she can go ahead, that would be great.
Yeah, sure.
Charlie,
Whenever
Charlie,
you're ready. Yep, that will be fine. Okay.
All right.
Thank you,
Thank
Dr. Saleh. Well, good evening again, members of the district board. A warm greetings from all the volunteers. I'm pleased to report that for the month of May, 191 Service League volunteers collectively contributed a total of 1,911 hours to the hospital. On June 1st, we held a new volunteer orientation, which saw a turnout of 47 individuals, including 31 high school students, 13 college students, and 3 adults. The orientation provided an overview of volunteer roles in each department and other relevant information. In other news, I'm pleased to announce that we are reopening the infusion center to volunteers. I have already trained one individual who is ready to join in that department, and we hope to onboard more volunteers to assist in that area. Today, I'd like to share the inspiring story of Karen Law, a remarkable young woman who has been awarded a scholarship from Washington Hospital. Karen, who has served as our volunteer for about a year, is determined and committed to making a difference in the medical field. I had the honor of attending her awards event at James Logan High School and had a chance to touch base with her about her journey. When I asked her what inspired her to pursue a career in healthcare, she explained that her desire stemmed from a childhood dream of becoming a doctor to help people. Over time, various experiences and science classes in high school deepened her passion for medicine. When asked about significant experiences that have shaped her goals, she reflected on her journey as a first generation student without any family background in healthcare. With neither of her parents graduating high school, she felt the weight of responsibility as a role model for her younger brother. Growing up, she faced challenges in gaining exposure to the medical field due to her background. She says that her volunteer experience at Washington Hospital marked her first introduction to a healthcare setting and deeply influenced her aspirations. Despite feeling terrified when submitting her application, her desire to pursue a career in medicine acted as a driving force. Karen says, before receiving the scholarship, I feared the burden of financing my education. I'm beyond grateful for the money that I have received from Washington Hospital Scholarship. It will help me fund my schooling at CSU East Bay as I strive to complete my nursing prerequisites. This scholarship has reinvigorated me and instilled confidence in my ability to achieve my dreams. Karen's story highlights how volunteering at our hospital has inspired and motivated so many of our volunteers to pursue careers in healthcare. And that's the end of my presentation. Please let me know if you have any questions.
Thank you very much, Sheila. It's always nice to hear from the volunteers.
Thank you so much, Dr. Stewart.
Thank you.
I'm still driving, but I could give my presentation if that's okay.
You can do it safely.
All right, that is fine. Go ahead, Dr. Soleil.
Oh, thanks. Hi, good evening, everybody. So we had the general medical staff meeting yesterday, which went very well, and the focus mostly was about trauma readiness in the upcoming trauma, first day on July 1st, obviously, that everybody's focused on. We introduced the new ortho hospitalist group, the new trauma program director, as well as the usual medical staff business. Again, that's the main thing. The thing I've been working on as well is getting the urology call schedule in place. We've been negotiating with the various urologists who do the call rotation, and that's all finally in place. And we're working on finalizing those contracts in the next few days. So that's a relief as well. In terms of the medical staff numbers, a grand total of 626 members. About half of those, 342, are active staff. The rest is distributed among administrative, 2 providers, advanced practice providers is 42, 103 ambulatory, 8 consulting, and 88 are provisional, and the rest are the other categories, smaller categories. Really, that's about it from point, unless anybody has any questions.
No? I think, okay, Mark, now that we know that you're also a driving force in the medical staff.
Thank
Be
you.
safe.
All right, take care.
Have a good evening.
All right, next we'll move on to the quality report, and I'd like to introduce Dr. Jack Rose. I know that he has presented other times to the Board of Directors, but I want to give a little bit of a background on Dr. Rose. Dr. Rose joined Washington Township Medical Foundation in early 2014. He received his undergraduate degree from Stanford University and his medical degree from Columbia University's College of Physicians and Surgeons. Dr. Rose received his medical and neurological training at New York Presbyterian Hospital's Neurological Institute, where he was selected as chief resident. He did a 2-year neurocritical care and stroke fellowship at the University of California, San Francisco. Dr. Rose is an expert in neurointensive care and cerebral vascular disease. He is also board certified in neurology as well as vascular neurology. His experience and leadership augments Washington Hospital's comprehensive stroke and neurosurgical programs. He personally provides the patients treated at Washington Hospital with the continuity of care that is critical when treating the full range of cerebral vascular conditions. He is co-medical director of the stroke program with Dr. Calda, and he is also chair of Washington's Continuing Medical Education Committee and its Institutional Review Board. And he will be presenting the annual update on the stroke program. Welcome, Dr. Rose.
Thank you very much, and good evening, everybody. Thank you, Kimberly, for the kind introduction. Can you guys hear me?
Yes. Yes.
Okay, great. I'm having some trouble pulling up the presentation from my end, but Maria Nunes, our stroke program manager, will be able to pull it up on her screen if you can allow her to share, and she can pull up the presentation.
Yes, please, go ahead.
Either that, yeah, Maria, if you want to do it, or we can do it, either one.
Or you guys can pull it
Yeah.
up, whomever.
Why don't we pull it up? Yeah, we'll pull it up, Dr.
Okay.
Rose. It's probably easier that way. All right.
Oh, perfect. There it is. Okay.
Yep.
So like Ms. Hartz mentioned, I'm pleased to give an update, the 2024 update about our stroke program. Next slide. So we have a small number of changes to the structure of our stroke program since last year. We have a new neurologist that joined our call group, Dr. Sandeep Walia, who's a stroke neurologist and neurointensivist like I am. And so this brings our group up to having 3 board-certified neurointensivists, in addition to Dr. Sharon Singh. We also added a 3rd neurointerventional surgeon, Dr. Dan Raper, who spends his time covering call for us as well as working at UCSF. So now we have 3 outstanding neurointerventionalists, Dr. Thomas, Dr. Carrington, and Dr. Raper, and this has allowed us to have 365 24/7 coverage of neurointerventional treatments for stroke. And the other leadership roles have been the same since last year. And again, I have to acknowledge the outstanding work of Maria Nunes, our clinical manager, who works closely with Michael, and nursing leadership, Terry Hunter, and our administration, including Larry and Kimberly. Next slide. Well, of course, our stroke program structure, the most important thing is that we are a multidisciplinary team that all focuses on the care of our patients. And from the time when stroke is potentially identified outside the hospital or inside our hospital system, we involve the EMS, we have ED doctors and nurses and staff. We have a unique structure where we have 24/7, 365 dedicated stroke nurses, which respond to potential stroke patients in the ER or anywhere in the hospital in a few minutes, as soon as possible. We have pharmacists that are available most of the time to accompany our stroke team in the ER and help make medical drug administration decisions. The neurologists and neurointerventional surgeons, like I mentioned. We coordinate with our radiology colleagues and radiology technicians to rapidly scan and assess our patients. And once they're treated and admitted to our hospital, we have outstanding stroke units, both in our critical care pavilion and the regular hospital floor, with outstanding nurses. We have a focused center on 6 West, where we try to take most of our stroke patients if they no longer or never need the ICU. And we have outstanding rehabilitation therapies, physical therapy, occupational and speech therapies, and really excellent case managers and social workers to help out. So it's a big team effort, and we're all focused on the care of our stroke patients. Next slide. And we focus on giving the appropriate treatment rapidly, as fast as possible, in as safe as possible manner. In order to provide very, very timely and emergent appropriate care, we initiated and have been practicing a overhead code system for acute stroke since 2016. It's called Code Neuro. You may hear it overhead if you're walking the halls of the hospital. And this allows us to rapidly identify potential stroke patients and get them evaluated, scanned, and treated as soon as possible, especially if it's a blocked artery stroke, which is the most common type of stroke, to potentially give them the clot dissolving medicine TPA within a very rapid time frame. And in order to that happen, we have to do a number of evaluations at a very quick time frame. And so calling this overhead code alerts the ED staff, the radiology staff, the neurology staff, the nursing staff to these patients to get them evaluated in a very, very rapid fashion so that we can get them evaluated for this potential life and or disability saving treatment. Next slide. Following up on the heels of the success of that code system for our patients that have a very large artery blockage, either in their neck or their brain, that might benefit from being taken to the neurocath lab to take out the clot from our one of our neurointerventional surgeons. We're in the process of developing and utilizing a second overhead stroke code system. We're calling it Code Stroke MT. MT stands for mechanical thrombectomy. Just means doing procedure to pull a clot out of the brain or neck artery. And we're doing this, and this is sort of the diagram that we've established to work on so that we can get these patients to the neurocath lab as quickly as possible and get this procedure done as quickly as possible. And so we're in the process of rolling this out in the very near future to improve the timeliness of this procedure. We're happy to have this rolled out soon and to improve our treatment times for this procedure. Next slide. How has our stroke patient volume has been over the last year and compared to years past? For the last, this is a chart showing you going all the way back to the initiation of our stroke program back in 2007. Our stroke volumes have averaged around in the low to high 400s. We didn't see a significant drop down in our volume during COVID, fortunately, but if you notice during 2023, this past year, we did see a slight drop, a little bit below 400 for the first time in many years. And we have realized that this is because Valley Care in Stanford and Pleasanton area has become a primary stroke center, which is a new development in the last year or two. And while our volumes have gone down a little bit, their volumes have gone up. And so we used to receive some stroke patients from that area, which are now appropriately being taken to the closer stroke center. And so that's why we have a decrease in the number of stroke patients. We hope to see this turn around or not drop any further in the next few years. And we're actively making sure that we advertise our abilities and capabilities and outstanding outcomes to everybody. But EMS is only taking those more local patients in the Pleasanton area to Valley Care rather than us. So we're not terribly worried about that, but we're watching that and tracking that on a monthly, quarterly, and yearly basis. Next slide. How are we doing in giving that clot-breaking medicine? That's what we call thrombolysis or thrombolytic therapy. You see in the dark green, that's 2022, and then last year is the light green, 2023. And those first columns are the total number of stroke patients, ischemic blocked artery stroke patients. And then the second columns where you see 39 cases each, which represent 13% and 16% of our blocked artery stroke patients receive the TPA, which is actually much higher than a national average. And we're happy to see those numbers. And those are a little bit higher than years past. So we're really doing an excellent job at providing this drug for our stroke patients. Only a small number of patients qualify for this medicine. That's why it's only in the teens that patients get this, but that's still much higher than the national average, which is about 5 to 10%. And in terms of doing blocked artery stroke procedures in the neurocath lab, we have around 6 to 9 in the last 2 years. Next slide. In terms of other procedural volumes over the last 4 or 5 years, The 2023 numbers are at the very bottom. Thrombectomies, that's the procedure where the neurointerventional surgeon takes the clot out. For a blocked artery stroke, we did 6 procedures last year, whereas it was 9 in 2022. And in terms of the second column, coiling or clipping, that's for brain aneurysms. We performed 13 of those, similar to the year prior. In terms of carotid stents, that's a procedure that has fallen out of favor because it hasn't been shown to be very effective, especially since it was primarily done in patients that did not have symptoms of narrowed neck arteries in the past, and more recent data suggests that medical therapy is better than doing stenting for these patients. And so that's why we didn't do any carotid stent procedures for stroke prevention in 2023. So that's a good thing, even though it's a lower number. But you notice that we do a lot of neck artery surgeries. Those are called carotid endarterectomies, or CEAs. So we did 20 last year, similar to the year prior. And then TCAR is a more less invasive procedure done by vascular surgeons to open up neck arteries for patients at high risk for the typical CEA procedure. And we didn't do any in 2023, but we did one in 2024 and only a few in years prior. So we're going to continue to track that. Next slide. In terms of our outcomes, we follow our outcomes of our stroke patients very, very carefully and report to the American Stroke Association through this program called Get With The Guidelines. And these are the 10 key core quality measures that we need to follow and report to this organization with a goal of being above 85% for each of these 10 core quality measures. And you notice that over the last calendar year, 2023, we are at 100% for 9 of these 10 measures, and only at 98% for one of the measures, which is still much higher than the target goal put out by the overall organization. Our internal goal is to be at 100%, and so we're almost there. Very, very good. And some of these measures are making sure our stroke patients get education and their families, whether we have assessed them for this clot breaking medicine, whether we do measures to prevent blood clots from developing their legs, to give them early preventative medicines to prevent a further stroke, counseling them about smoking cessation, giving them a particular cholesterol lowering medicine, making sure they're on the right blood thinner if they happen to have atrial fibrillation, assessing their swallow, assessing them for rehab, and following different measures of stroke disability. Next slide. In terms of the IV thrombolytic therapy, this TPA medicine, we can give very, very acutely for a subset of our stroke patients that get to us in a rapid time frame. We've been following not just how many patients we're able to treat with this medicine, but how fast we can provide that medicine for them. The goal used to be to try to get the vast majority of the patients treated within 1 hour from the time they hit our emergency room door. That goalpost has shifted down to 45 minutes and even 30 minutes over the last several years, with the national organizations trying to get people to give this drug as fast and yet safely as possible. And in the last 3 years, you see here that it's the column on the right side showing you that in the last 3 years, our median time to give this drug went from 49 to 44 minutes, and now our median time is 30 minutes, which is really outstanding and a real improvement that we've seen over the last 1 to 2 years. Next slide. We also don't just care about giving this drug as much as we can and as fast as we can, but we want to make sure we're doing it in a safe manner. There is a serious potential side effect of this medicine. It's brain bleeding, and we call that symptomatic intracerebral hemorrhage if it actually affects people's neurological condition, not just sort of an asymptomatic little bit of bleeding. But if it's a significant amount of bleeding, we want to know about it and make sure that we did everything possible to prevent it. The average risk for that is about 1 to 2% per year. So it's relatively small, but it's not zero. And we follow this on a frequent basis. And if you look, the top several columns are looking over the last from 2017 to 2021, we had only a few cases, which average out to about 2% risk per year. And then in 2022 and 2023, we did not have any symptomatic brain hemorrhage. The A and T on the side there just reflects something that I'll explain a little bit later, but we did switch the particular clot-busting medicine that we use. We switched it from the standard Alteplase to another similar TPA medicine called Tenecteplase in early 2022, and that has helped us allow us to give this drug faster and even potentially more in a more safe fashion. So even though we've switched a particular drug formulation, we haven't seen an increase or significant change in the safety or in terms of brain hemorrhage risk, which we're happy to see, and we're following ongoing. Next slide. In terms of how well our patients are doing in terms of their disability, when they are discharged from our hospital to home or to a rehab facility, we use a standard measure of disability. It's called a modified Rankin scale. And if you get a score from 0 to 3, you're considered good to fair outcome. 4 to 6 is a poor outcome. And if you compare us to all other hospitals that are reporting into the stroke guideline data, you see that at the time of discharge, 63% of our patients have a good or fair outcome compared to a worse outcome compared to other hospitals, which only have about 28% of their patients at discharge assessed to have that fair to good outcome versus a worse outcome. So we're happy to see this, and we think it both reflects our patient population as well as the outstanding care we're able to provide our patients. Next slide. In terms of our mortality, what the risk of dying is if you're diagnosed with a stroke and you're taken care of at the Washington Hospital. This chart on the left side here is tracking back to 2018. You see that we're the green line there, and these numbers are in percentage risk. So the latest percent risk of mortality when you're diagnosed with a blocked artery stroke at Washington Hospital is about 4.6%, which is very similar to other hospitals statewide, slightly above 4%. In 2023. So this has been very similar. We're slightly higher some years than others, but it's not a significant difference compared to other hospitals. That same information you can see on the very right column where it says ischemic stroke with the NIH stroke scale score in 2023, 4.6 compared to 4.01%. Compared to the 33,000 other patients in other hospitals. So we're very similar in terms of risk of dying after diagnosis with stroke. And then the green numbers in the middle are not just the blocked artery stroke patients, but our bleeding stroke patients as well. You notice that those numbers are much higher. You have a higher risk of dying if you have a bleeding stroke than you have a blocked artery stroke. And in 2023, our average combined bleeding and blocked artery stroke mortality risk was about 22%, which is slightly higher than the statewide average of 18%. And I will note that we do get a high number, not a high, but we do have several number of very sick bleeding stroke patients that are transferred from other emergency departments to us for specialty care of brain aneurysms, which have a very, very high mortality risk. So this isn't something that we're concerned about. What we track over time, and the Stroke Association says that we're still on par with other hospitals. We're not above risk for dying. Next slide. In terms of where our stroke patients go after they leave our hospital, the first column here, you see that about 50 to 60% of our patients go home, and slightly under 1/5 of the patients go to a skilled nursing facility. We have less than 10% of our patients going to acute rehab, and then very small numbers to long-term care or that expire or go to hospice. So we check that, follow that over time, and we're hoping to see more of the patients going to acute rehab than skilled nursing if we're able to do so. But we're happy to see that a vast majority of our patients are able to go home after they're cared for at Washington. Next slide. In terms of performance improvement, this is a slide going back to the beginning of 2019, showing you how fast we can give this clot-breaking medicine within an hour of hitting our door. And you see that we're over in 2023, we are at 100% ability to give the drug within 60 minutes, which is better than the last several years where we've been in the mid to high 90%. Next slide. In terms of giving this drug within 45 minutes, when there is a reason, without reason for delay, we're able to give that also now at 100%. Sometimes we have to get some additional information within that first 45 minutes in order to safely give the drug. And the goal is to be above 75%. And this is the data that's reported back to us from the guidelines. And so we're above that 75% goal and higher than we were in years past. And we think that this has to do with the new formulation of a thrombolytic drug that we're able to give. And so this is really outstanding outcomes that we're seeing in terms of that 45-minute goal. And then the next slide will show you what it looks like for the 30-minute goal. If you exclude people for reasons for delay, all those that qualify potentially to get the drug within 30 minutes, we were able to do so. So we've really tremendously improved our rapidity of giving this drug as fast as possible. And it's not just a feather in a hat. The faster you can give this drug appropriately, the better the chances or good outcome in your patients are. And so we really work hard to achieve these time goals. And we're happy to finally get above that 50% goal for the first time ever. Next slide. And if you compare us to other hospitals in terms of the rapidity of giving this drug, this is some data going back to the last several years. We are the green bars, the other hospitals are the red bars. You see that over the last several years, and including 2023, we're better than other hospitals in terms of giving this drug as fast as possible. So 94% for this measure, greater than 84% for the other hospitals. Next slide. 45 minutes, similarly, almost 90% versus 62% the last year that compared to other hospitals. Next slide. And this is that new TPA that we've switched to in the last year and a half, or 2 years now. It's called Tenecteplase as opposed to Alteplase. And one of the great things about this version of the drug is that we can keep it in the emergency department. It doesn't have to be in the pharmacy, and it can be given with just a 30-second IV push as opposed to an hour-long drip. So it allows us to give this very, very rapidly, and it's available in the emergency department. It can be given by our stroke nurses right at the bedside, even sometimes in the CT scanner. Next slide. And we also work on making sure that all of our appropriate stroke patients that can benefit from a cholesterol-lowering medicine called a statin, that they get it. And we've been well above the 85% target for this for the last several years. This is our performance improvement plan that we rolled out that allowed us to achieve such high numbers. And we're going to sunset this PI plan because it's working so well. Next slide. Some of the things we can improve on is getting our CT scans that need to be done prior to potential treatment of our stroke patients, is to get that read officially by a radiologist. In the last several years, we've been in around 90%, very similar to other hospitals. We had a slight dip in 2023, down to 72%, worse than other hospitals. And the vast majority of these cases were because of delays for our Nighthawk after-hours radiology reading. And we've been tracking all of these fallouts. And when we realized this with some other problems with the Nighthawk radiology group, we're now in the process of switching after-hours radiology group. So we anticipate that we'll go back to our much higher percentage of the time that we're able to meet this metric. And we're happy to switch to a new group. And we think that this will solve this problem that we identified within the last year. Next slide. In terms of our, our ED doctors can very rapidly assess our stroke patients, and we do an outstanding job of getting a blood glucose tested for all of our stroke patients, better than other hospitals for all stroke patients. So we're doing really good from that standpoint. Next slide. And then one of the measures that I mentioned before, we're trying to get our patients to a neurocath lab that are candidates for this procedure, clot removal procedure. And we're trying to, this is our performance improvement plan, to improve the timeliness of this procedure. The blue triangle is the sort of the times that we had in 2021. The orange triangle are the times that we had in 2022. And in 2023, this last year, we've dropped the average time to the door to giving taking the clot out, dropped it down. We want to move it more towards the 90-minute time frame. So we're going in the right direction already, and we want to even more rapidly get our patients to the neurocath lab if they'll benefit from it. So we're working on that as well. Next slide. And this is sort of the workflow and one of the ways that we can speed up our timeliness of this procedure is we can find out where any potential delays are. And so we have an audit sheet here that our stroke nurses complete for every neuro IR cath case. And we can see where there may be some delays and how we can speed up the process. So this is one tool that we're using to improve our speeds. Next slide. And we're also trying to work on, for the last several years, educating the public about getting to the hospital via 911 EMS, not driving themselves or their loved one or having a friend take them to the hospital when they suspect stroke. And we were doing a little bit better in terms of having more patients show up by 911 EMS pre-pandemic. During the pandemic, that sort of evened out about 50-50. And ever since then, we've still been about 50-50, meaning half of the patients will show up via EMS versus half will be a walk-in or be brought in by a private vehicle. So we're still trying to educate the community to try to get more people to come by 911. And we're going to follow this and track this over time. But it's been a challenge to improve this above the 50%. Next slide. In terms of our patient satisfaction, we don't just want to give excellent care. We want to follow up and make sure our patients are doing well after they leave our hospital. And we use a company that has a very, very good yield at contacting as many patients as possible. Their yield is well in the 90%. Following with the patients both at 7 days after discharge and at 90 days, at 3 months after discharge. And they're able to ask them a whole bunch of questions and data that we can get to follow up, where they're located, what kind of disabilities, if any, they have they followed up with their doctors, do they know what the warning signs of stroke are, etc. One of the things we noticed is that for the last several years, not a high percentage of our patients had followed up with their primary care physician within a week of discharge, and we wanted to improve that. And so one of the things we worked on was to try to make sure that we gave the patients either an appointment already with their primary care on discharge, or make sure they knew to call right away and whom to call. And we see, next slide, one of the things that we've seen, this is just more additional questions that we ask and get data about at 90 days. Next slide. So we created this discharge flyer to have patients follow up with their primary care doctor as soon as possible. Next slide. And you see that we over the last several months, we've definitely seen higher percentages of our patients following up with their primary care doctor within a week. So this was 1 month where we had 96% of our patients that were discharged followed up with their primary care doctor already, compared to the average of 50-60% that we had seen before. So this varies, but we're definitely seeing improvements with this discharge flyer that we've rolled out. Next slide. We do a lot of education. I give a monthly case conference where we go over 3 interesting stroke cases from our own hospital every month. And it's an interactive educational conference. There's CME credit and CEU credit for our nurses, and it's done on Zoom and is well attended. And it's a good way for us to educate ourselves on optimal stroke care and how well we're doing, and particular interesting topics in stroke. Next slide. We also do a lot of patient education, both the patients and their family. One-to-one, we tailor it to the patient and make sure that they understand everything about what stroke is and what the risk factors and what their individual plan is to prevent stroke in the future. Next slide. We do community education as well. We work with our EMS people to educate EMS and to share data back and forth. We have a stroke support group, which we're working to have more active than it was pre-pandemic. Next slide. We do quarterly stroke education series. We have health and wellness events. I have one next week, for example. We do concert in the park series. We give Facebook Live presentations. We do health fair booths and other educational offerings for the community, and our newspaper articles. Next slide. Performance achievements, we're almost done. We received the Gold Plus and actually a Gold Plus Elite or Silver Elite Award for stroke this past year. We've definitely increased the rapidity of our TPA administration, like I showed you. We're working on extending our stroke care services to San Joaquin Valley and work together with other marketing strategies to increase the number of our neuroscience and stroke patients. Dr. Ash Jain is the PI for a pivotal stroke prevention trial called CREST-2, which we continue to participate in. It's a multi-center trial. And many of our team members attended the Pacific Stroke Association conference this past month. And most importantly, we just successfully passed a Joint Commission Advanced Primary Stroke Recertification with very, very high marks from the Joint Commission reviewer. So we're approved, we're certified for another 2 years at the advanced primary stroke level. Next slide. In terms of our program goals for the following year, we're going to continue to work to give our thrombolytic medicine as fast as possible and use our, get as many stroke patients that will benefit from our neuro-IR procedure to the cath lab as fast as possible and improve our numbers. And in the future, we're working on trying to achieve even high advanced levels of stroke certification, certified thrombectomy capable, or even comprehensive level of stroke certification. Next slide. And that's about it. And I'd be happy to take any questions if you have.
Thank you, Jack. This is Bill Nicholson. I just have two questions. One is, do you foresee any expanded indications for either thrombolysis or mechanical thrombectomy? I know we've expanded the mechanical thrombectomy indications. What do you see in the future for indications?
Yeah, we're so far we haven't seen any clinical trial data to expand the time window for TPA, which is currently at 4.5 hours. There are multiple studies looking at trying to expand that, but so far it has not shown benefit or increased risk. I'm not going to rule that out as a possibility, but definitely, like you mentioned, we've been able to extend the time window for doing neurocath lab procedures up to 24 hours for particular patients. But those are only patients that have blockages of the largest arteries. So it's going to be hard to extend beyond that, but we're still being able to treat patients more aggressively, acutely than ever before. And I think most of the improvements in the next several years are going to be with potentially bleeding stroke patients, not the ones that have brain aneurysms, but just bleeding into the brain tissue itself. There was just one study that was published suggesting that a subset of bleeding stroke patients may benefit from a particularly minimally invasive clot removal procedure. So we will be looking into that potentially for our stroke program in the near future.
Well, you anticipated my second question, was what's on the horizon for the hemorrhagic bleeding stroke patients?
Yes, so we think some minimally invasive endoscopic guided procedure may benefit. The problem is that it only it targets not the most common type of brain hemorrhage patients. Those are patients that have brain hemorrhages from deep areas of their brain from high blood pressure. But if they happen to have a clot more towards the surface of the brain, this procedure may potentially benefit them. So we're working with our surgeons to potentially do this for the subset of patients that might qualify.
And that would be a surgical procedure, not
it's a surgical procedure in the operating room.
Okay. Thank you, Jack.
Sure.
Jack, I have two questions. Great presentation. It's always refreshing to know that the total incidence is going down. As far as I'm concerned, I think that's a good sign. The preventive measures are, being effective. The question I have is, are you seeing higher incidence of stroke among younger population that's less than 50? If so, is it anything to do with post-COVID?
Yeah, our highest percentage of stroke is still in the older age populations, older age groups. We really didn't see a significant uptick in strokes in the young patients. I think that there was a very, very slight potential increase around COVID time, but it wasn't a significant increase like we thought we might see. Much of the thrombotic risk in terms of COVID was venous and not arterial, but there was a slight increase with COVID. So we haven't seen a large increase, but we're definitely we're able to assess our stroke patients in the young much more accurately than ever before with all of our echocardiography techniques and assessing them for reasons like PFO or septal defects. And we're able to close congenital heart defects and stuff like that for young patients. But we haven't seen a huge increase or any significant increase since COVID.
Thank you.
Mhm.
All right.
All right, thanks.
Thank you very much.
Thank
Thank
you
you.
for allowing us to talk.
Finance
All
report?
right, now we're going to do the finance report.
Yep. Happy to share the final financial results for April 2024. Our inpatient average daily census of 151.7 was short of budget by 11.6 for the month of April. And on a fiscal year to date, our average is 157.3 against a budget of 163.1 for a shortfall of 5.8. Combined average daily census, 161 was actual for April on a budget of 171.8, off by about 11. And then fiscal year to date, we sit at 168.2 versus a budget of 172 for a difference of 4. Discharges for the month of April were 825 on a budget of 869. And on a year-to-date basis, we sit at 8,800 actual versus a budget of 9,500. So for shortfall of about 700 on discharges. Patient days for the month of April fell short of budget by 349 at 4,551 versus a budget of 4,900. Fiscal year to date, we trail our budget by about 1,800 on patient days. Outpatient observation equivalent days were 279 versus a budget of 256. And on a year-to-date basis, our observation days exceed budget by around 600. Average length of stay for the month of April was 6.22 on a budget of 5.18. I will note that we had 2 very significant outliers that if we pulled them out of the calculation, our average length of stay for April would have been 6. On a year-to-date basis, average length of stay is 5.43 on a budget of 5.23, so just under 0.25% difference. Next slide. All right, case mix for the month of April was 1.623 on a budget of 1.563, so a higher case mix of 0.06. On a year-to-date basis, we are above budget by 0.034 on our case mix, so higher acuity. Deliveries for the month of April were 114 on a budget of 120, and on a year-to-date basis, deliveries sit at 1,252 versus a budget of 1,270, so we're off 18 at the end of April. Surgical cases were short of budget by 16 at 465 and are basically on budget on a fiscal year-to-date basis through April at 4,693 versus a budget, or excuse me, they're over budget at 4,691. Cath lab was right on budget at 196, and on a year-to-date basis, we're at 1,739 versus a budget of 1,992, or a shortfall of 253. I will point out that that is 60% less than the shortfall we had last year at this time. Outpatient visits, 9,068 on a budget of 7,800. So positive performance of 1,248 on the outpatient visits. And on a year-to-date basis, our outpatient visits are 85,980 on a budget of 84,122. So positive 1,900 there. Emergency visits continue to outperform, 4,991 on a budget of 4,500, so about 500 over budget, and on a year-to-date basis, we're short of budget by 227. So on the next slide, we have the detail for the surgical cases. Just a couple of things to point out here. 465 on a budget of 481. The biggest shortfall here was the orthopedic cases, with Dr. Saw moving about 30 cases a month to the WASC. Kind of explains the shortfall in April. And then if we move down to the cath lab, the cardiac is 105 on a budget of 80. And a lot of that is Dr. Agarwal, who is now performing a lot of procedures within the cath lab. Some of our operating indicators. Productive FTEs were 1,433 for the month of April on a budget of 1,406. So we are over. That's not good. The 27. On the non-productive side, we're at 200 on a budget of 204. So we're positive 4. And when we blend those two together, our total FTEs were 1,633.3 on a budget of 16105. So we're off our budget by about 23 FTEs. And that shows up in our FTEs per adjusted occupied bed at 6.22 on a budget of 6.10. On a year-to-date basis, we continue to be under our budget at 6.01 on a budget of 6.27. Next, we get into the gross revenue numbers and the contractuals. Our gross revenue for the month of April was $194,460, so $194,460,000 on a budget of $192 million. So a positive difference of $2.3 million. On a year-to-date basis, we are within $5 million of our budget number on gross revenue. Contractual allowance was 75.59, or about 1 1/3% higher than the budget of 74.28. Then we had provisional bad debt, which has performed better than budget at $2.9 million versus a budget of $3.5. And on a year-to-date basis, we are under budget as well by $223,000 on our provisional for bad debt charity. So adding those up, our total deduction for the month of April was 77.12, or about 100 basis points, or 1 percentage point above the budget at 76.1. And on a year-to-date basis, we sit at 76.93 versus a budget of 76.39. Incorporating those into our P&L, draw your attention to the third line down. Net operating revenue for the month of April was $45,500,000 on a budget of $47,400,000, or a shortfall of $1.9 million. Operating expenses for the month of April were $44.1 million on a budget of $47.5 million. On a year-to-date basis, net operating revenue trails by about $16 million through April, and then operating expenses are under, which is a positive performance against budget of $4 million. Leaving our net operating income positive $1.3 million on a budget of negative $81,000. So positive variance there. And on a year-to-date basis, we're closing the gap. We're at a negative $4 million on net operating income on a budget of a positive 8.8. So we still trail our budgeted number by $12.9 million. Moving down to the non-op side, I will point out in the fifth line down in the non-op side, $4.7 million from the foundation donation. We mentioned that the last time, and that really lifted our non-op. So if you go down to the non-operating income line, third from the bottom, $4.3 million for the month of April on a budget of a positive $89,000, bringing our non-operating income for the year to $15.2 million on a budget of $3.1 million. All in, operating and non-operating income, net income, $5.7 million on a budget of $8,000 for the month of April. And on a year-to-date basis, we sit at 11.2 positive for net income on a budget of 11.9. That was the GASB number, and as you know, we like to compare ourselves to the other nonprofit healthcare systems that use FASB. So the numbers change. As you can see, for the month of April, we moved from 1.3 million positive on net operating income to 755,000. And on a year-to-date basis, we were off around 4 million and change, and now we're off 10.7 according to FASB's accounting rules. And then if you move down to net income, we sit at, for the month of April, we have 6.9 million positive on a budget of negative 203,000, so a pickup of $7 million, bringing our actual net income through April to 6.6 million on a budget of 9.6 million. And then finally, on this last slide in the middle of the page, we do report and track EBITDA, which is our cash flow, our operating cash. So for the month of April, our EBITDA was 4.6 million on a budget of 2.9, so a positive variance of 1.7 million. And our year-to-date EBITDA is 28.8 on a budget of 39.6, so we're trailing that by about 10.9. And that concludes the report for you.
Thank you.
Any questions for April, or I can move on to the May? All right, I am going to present the May 2024 preliminary numbers, and starting with our preliminary gross revenue trend. As you can see, patient gross revenue of $212 million for May was favorable to the budget of $208.4 million by $3.6 million or 1.7%, and then also higher than May of 2023 by $9.1 million, 4.5%. Looking at it as where we stand fiscal year to date, total gross revenue of $2,223 million was unfavorable to the budget of $2,224 million by just $1.4 million or 0.1%. So this month we did make up, as Tom said before, we were about $5 million from our budget. So after 11 months of activity, we're almost aligned with budget in terms of gross revenue. Moving on to our inpatient gross revenue. Inpatient gross revenue of $118.4 million was unfavorable to budget by $11.7 million or 9%, but again was $6.1 million or 5.4% higher than May of 2023. Year-to-date, gross revenue of $1.27 billion was unfavorable to the budget of $104.4 million, by $104.4 million or 7.6%. And looking at our outpatient, you'll see really we've continued to outperform our budget in our outpatient gross revenue. It came in at $93.6 million, which was favorable to budget by $15.3 million, or 19.6%, and $3 million or 3.3% higher than May of 2023. Year to date, our outpatient gross revenue of $949.3 million was favorable to the budget by 12.2%. Now moving on to our key operating statistics. Starting with the left-hand side, the top box, the average length of stay of 5.16 was favorable to budget of 5.17 by just 0.01 or 0.2%. And the average length of stay was lower than May of 2023, which was 5.30, and it was 2.6% better. Moving on to our outpatient observation equivalent days came in at 291, which was unfavorable to the budget of 282 by 9 or 3.2%, but shorter than May of 2023 by 7%. Then going on to that, inpatient average daily census of 152.1 was unfavorable to budget of 169.7, by 10.4%, but higher than May of 2023, of the average daily census of 146.8. Then lastly, looking at the combined average daily census, came in at 161.5, which was unfavorable to budget of 178.8 by 9.7%, but 3% higher than May of 2023. So given our less than budget in terms of inpatient length of stay, average length of stay, you'll see that discharges came in at 923, which were unfavorable to budget of 1,800 by 95 or 9.3%. And discharges were 2.8% more than May of 2023. Moving on to patient days trend, patient days of 4,716 were unfavorable to the budget of 5,262 by 546 days or 10.4%. Patient days were 3.6% more than May of 2023. And really that decrease in the patient days was spread throughout all the departments, ICU, IMC, telemetry, OB, and adult med surg too. However, we did have a very busy OR schedule, and so total surgeries in May came in at 526, which were 9.4% favorable to the budget of 481. And surgeries were 11% more than May of 2023. Our inpatient surgeries at 238 were favorable to budget by 37 or 18.4%. And 24.6% more than May of 2023. Our outpatient surgeries at 288 were favorable to budget by 2.9% and about 1.8% more than May of 2023. And even we also did, as we've talked about, had a number of our orthopedic cases moving to our ambulatory surgery center, and that's we had about 44 or so from Dr. Dearborn, and then also about 30 cases from Dr. Saw. I also just want to mention that I think we've talked about, we started our robotic program and sort of slowly moving that forward. We did do 3 cases in May. Dr. Coranthia Chanta and Dr. Jennifer Chan did those cases in May. So very excited to be starting that program. I know Larry and his team and many others have been involved in starting to roll out that program. Now looking at the surgical activity broken down, you can see that orthopedic surgical cases were unfavorable to budget by 3 or 1.5%, and were 11% less than May of 2023. And again, just showing how it's continuing to move to our ambulatory surgery centers. Our neurological cases came in favorable to the budget by 5 or 17.9%, and were 9 or 37.5% more than May of 2023. Cardiac cases, they were also busy, came in favorable to budget by 6 or 60%, and were 4 or 33.3% more than May of 2023. Our vascular surgical cases were favorable to budget by 1 or 2.6%, and 14.3% more than May of 2023. Endoscopy cases were favorable to budget by 17 cases, 15.2%, and 44.9% more than May of 2023. And then lastly, our all other surgical cases combined were favorable to budget by 19 or 20.2%, and 18.9% more than May of 2023. Also moving on to our cath lab, continued around the same trends that we've been seeing in the last couple of months. Cath lab cases for May came in at 195. It was unfavorable to the budget by 16 or 7.6%, but 7% more than May of 2023. Our inpatient cath lab cases came in at 93, which was unfavorable to the budget of 121 by 23.1%. and about 10.6% less than May of 2023. Outpatient cases at 102 were favorable than the budget of 90 by 12 or 13.3%, and 30.8% more than May of 2023. As you can see here, in terms of the breakdown of our cath lab activity, Again, our cardiac cases continue to be favorable to budget, came in at 16.5% more than budget and 26.2% more than May of 2023. Our non-vascular IR and peripheral vascular cases both were unfavorable to the budgets, and our neuro IR cases came in right on budget. Looking at our deliveries, we've continued to see a little bit of a slower month with our deliveries coming in at 117, which was unfavorable to the budget by 26 or 18.2%, and were 18.8% fewer than May of 2023. Our C-section rate for the month was 36.8%, and year-to-date, we have total deliveries of 1,369, which was unfavorable to the budget by 3.2%. Non-emergency department outpatient trend, we saw visits that came in at 8,950 that were favorable to the budget by 556 or 6.6%, but just fewer than the May of 2023 by 0.8%. The growth that we primarily was driven by imaging services that were 28.6% favorable to the budget, and diabetes education visits that were 29.3% favorable to the budget. Moving on to our emergency department visits, they continue also to be higher than what we budgeted. Emergency department visits came in at 5,404. They were favorable to the budget by 306 or 6%, and were 5% more than the prior year. Lastly, moving on to our gross revenue recap. Most of this you can see aligns with sort of where we stand with the volume. As mentioned, our total gross revenue was $3.6 million higher than the budget. It's driven by surgical services that was favorable to the budget by 9.5% or $3.6 million, and also cases were 9.4% favorable to budget. Our cath lab cases were 7.6 unfavorable to the budget, but given the mix of the cath lab cases, our revenue was just 2.6% unfavorable to budget. Room and board was unfavorable to budget by 9.6%, and as you know, patient days were also unfavorable to budget by 10.4%. Our birthing center delivery revenue was unfavorable to budget by 14.2%, and deliveries were unfavorable to budget by 18.2%. Emergency department revenue, as you can see, came in at 6.9%, and visits were also above budget by 6%. And lastly, our ancillary services revenue was favorable to budget by 4.6%, and primarily driven by our infusion services. Looking at the payer mix, we can see that government-sponsored patient revenue made up 75.5% of total gross revenue. This was unfavorable to the budget of 72.3% and higher than the prior year's percentage of 71.4%. HMO gross revenue was 1.7% of total gross revenue, unfavorable to the budget of 2.2%. This was also lower than the prior's percentage of 2.4% of gross revenue. Our PPO gross revenue was 20% of total gross revenue, unfavorable to the budget of 24.1%, and also the PPO payer mix was lower than the prior year's percentage of 23.6%. And at least some of this decrease in PPO is driven by some of the movement of our orthopedic cases to the ambulatory surgery center cases. So not leaving the healthcare system altogether, but not at the hospital. Last, our private pay gross revenue was 2.8% of total gross revenue, was unfavorable to the budget of 1.4% and higher than the prior year's percentage of 2.6%. There was a total of about $2.4 million in charges from out-of-the-country patients. In May, there were 5 accounts with charges exceeding $100,000, totaling about $1.3 million. Moving on to our productivity indicators, was favorable in terms of this. Our productive FTEs, as you can see, were favorable to budget by 76.3 or 5.1% and came in at 1,429.5 FTEs. This also included 3,385 hours of education hours. We've had a lot of education for our trauma program. Thank you. I was trying to get it, had stroke in my mind, but trauma, getting ready for trauma. In terms of non-productive FTEs, they were unfavorable to budget by 21.3 or 13% at 185.3 FTEs. So our total FTEs of 1,614.8 were favorable to budget by 55 or 13.3%. And total FTEs per adjusted occupied bed of 5.94 was favorable to the budget of 6.14 by 3.4% or 0.21, and also better than the prior year that came in at 6.11. So staff did a good job of flexing this month. Then moving on to our outpatient statistics with Washington Township Medical Foundation. Clinic visits were unfavorable to budget in May by 802 or 4.1%, but 2,874 visits or 15.4% higher than May of 2023. The majority of the unfavorable variance, 597 visits, was basically due to having four open provider positions. And then also the remaining, we've had a few new primary care physicians that have been ramping up or are moving on in terms of out on leave of absence. Moving on to our radiation oncology center. In May, the treatments were 281 or 191 or 40.5% below the budget of 472. I think we've talked about the need for less treatments, and we'll be looking at some other measurements to show. I do want to say, though, they were very busy this month. They had 50 new patients referred to the center, which was 29 higher than their average of 21.31. So that was really a record month in terms of that. They had 19 new treatments starts, and they had 32 new treatments seen in the clinic, which was 7.2 higher than the fiscal year 23 average of 24.8. So it has been busy recently for them. Then moving on to our preliminary outpatient statistics for the Development Corporation. Overall, the visits of 2,152 were unfavorable to the budget by 108 or 4.8%. And this was really driven by the Washington Outpatient Rehab Center visits, which was unfavorable to budget by 10.9%. We did have some of our occupational therapists and physical therapists that were out for some extended periods of time. Our Washington Outpatient Surgery Center cases were favorable to budget by 58 or 11.8%, and our Peninsula Surgery Center cases were favorable to budget by 19 or 28.4%. Lastly, looking at our key financial statistics, days cash on hand for May ended at 140 days, an increase of 4 days from the prior month. A lot of this was due to $1 million of the increase was in operating cash. We've really put in revenue cycle, and that team has really worked hard in terms of improvements in their cash collections, and that has been helpful. And then also we did see an increase in investments. And then lastly, there was $299,000 in charity care adjustments in May of 2024. And year-to-date, charity care adjustments are about $2.6 million. So those are the preliminary results for the month of May. Any questions? All right, I can move on to our calendar. I am going to start with the Employee of the Month for June of 2024. And it's Blessilia, known as Bless Bautista. She's a CNA, and want to give a little bit about her. Bless came to the United States from the Philippines. She hoped to find work doing what she loves, caring for patients. Bless joined the Washington Hospital family nearly 28 years ago as a certified nursing assistant, working on 3 North and 4 West as a and as a CNA. She helps provide patients with an extra care when they need it the most and always ensures that they feel comfortable. Through her dedicated work and positive attitude, Bless contributes to a good atmosphere for her colleagues too. As one would put it, Bless comes to the floor with a loving heart. She is remarkable with all of our patients. Bless is a member of the LIFT team and is part of Central Transport. Some patients may need extra assistance due to mobility issues. As a member of the LIFT team, Bless is often called to help transfer these patients from their beds to chairs or other areas. She enjoys providing extra care, TLC as she calls it, to these patients. Our patient-first ethic means we base our actions on the best interests of our patients, and this extends to our coworkers. According to her supervisor, Director of Clinical Operations Improvement, Jimmy Chang, Bless truly embodies the patient-first ethic. He says Bless's dedication to her work, coupled with her compassionate nature, makes her a role model for all of us. We are incredibly fortunate to have her as part of our team, and her presence enriches the lives of both our staff and our patients. Bless is a Hayward resident who has 2 children and 3 grandchildren. They all live in Reno, so whenever possible, she is planning her next trip there. So, congratulations. She truly deserves Employee of the Month. All right, moving on in terms of our health promotion and community outreach efforts for the month of May. I want to just start with May 6th through May 15th was Healthcare System Week, and we had a number of activities for the week, and I think I had talked about it last month and really wanted to recognize all of our staff and physicians throughout the whole healthcare system for all the work that they do. On May 10th, we participated in the Special Olympics at James Logan High School, and they had 514 student participants, 60 student volunteers, and 234 staff members in attendance. May 11th, we hosted the Spot Me Free Skin Cancer Screening. Dr. Sunil Dewan participated with us on that. And it was at the Nakamura Clinic, and 35 community members were screened. You'll also see throughout, we continue to do education around choking first aid, and Betty Goodwin, our nurse practitioner from the emergency department, has been very busy doing this, and I will just say that it truly has made a difference, and I know that she recently had educated someone in one of the local restaurants who ultimately took that education and helped save a life. And so really what is being done in the community is truly making a difference. So I want to thank Betty Goodwin and Angus Cochran and all the team that's been out there doing that education. On May 14th, one of our physical therapists, Larry Aseo, he was at Acacia Creek and Masonic Home Senior Living Communities and did education on Let's Move, Staying Active as You Age. May 16th, Bike to Work Day, and we had an Energizer station outside of Washington West. We had 28 cyclists stop by. May 16th, we did our Celebration of Life in Anderson Auditorium, and 90 people attended. And then May 16th, also, our Fremont Leadership Class Project. We had two of our people from the healthcare system participated and in Leadership Fremont, and they talked about their project with the Afghani Elderly Association. And I just want to congratulate them and all the work that they did. They raised over $48,000 for the Afghan Elderly Association, so it was great from that standpoint. On May 21st, and we heard from Sheila Vijay today, and her and Angus Cochran presented the Washington Scholarship to Karen Law, who is James Logan High School graduate. May 22nd, we also hosted the Leadership Fremont graduation ceremony. On June 4th, Elisa Curry did a talk on fall prevention and recovery at the Age Well Center in Warm Springs, and they had 13 senior attendees. June 6th, Dr. Bryant Bonner, orthopedic surgeon, did an education session on updated treatment for hip pain and arthritis on Facebook Live and YouTube, and we had 82 live and 422 non-live views. So it's out there. Again, on June 7th, we did some more education in terms of choking and at the Fremont Family Resource Fair. Also, June 10th, we Fremont Debate Academy and Anderson Auditorium. We hosted them and 60 middle school students, and again talked about choking, first aid, bike safety, and stop the bleed. Then on June 11th, we did choking first aid training at La Campagna Restaurant in Newark. And then you can see a number of the pictures of some of these the different events that we were at. A lot of events.
Yeah.
And this is the list of some of the upcoming ones that we have. Again, on June 18th, we have choking first aid at the Birdhouse Beer Garden in Union City. We also have June 15th, we'll be at the Fremont Pride Fair, and it'll be hosting a health education booth. June 19th, Dr. Acosta, our psychiatrist, is going to be talking about mental health in the LGBTQIA plus community. I do want to mention on June 24th, we'll be hosting the Trauma Center ribbon cutting. I just want to pause right now on that to say we did have our designation survey on June 5th last week, and this is with Alameda County EMS, and we had a number of surveyors here, and they did that designation survey. I think we had about 10 or 15 people that were surveying throughout the house with 2 main surveyors, and want to say that we received a lot of great feedback. We had a few follow-up items, but we had a lot of praise from everyone about all the hard work that we have done to be ready. We were then given the next day a number of items to follow up on, and so since that time, our team, led especially by Dr. Chet Morrison, Ginger Miramontes, and Jen Kubis, has been working hard on all of those follow-up items. We met today with the county, and they gave us, literally a few hours ago, the go-ahead to start seeing our first patient on July 1st. I do just want to recognize this has been a true journey, and the journey is not ending. It is continuing as we see our first patient, but it's been a true collaborative effort with many of our staff, our managers. I mentioned 3 of those teammates, also with Terry and Larry and Donald and many others, and Bishop and Associates, and many that really contributed to being able to say that we're going live on July 1st. So very excited, and want to thank so many people for all the hard work that they have been doing. So very excited about that. Yes. All right. I know the next one, you heard from Dr. Rose that we received our official advanced primary strokes recertification notice from the Joint Commission, so we're happy about that. Also want to mention that on May 11th, Assembly Member Alex Lee recognized Dr. Seema Sehgal, who I know many of us have worked with, and she's a local psychiatrist, and she was recognized as part of the 2024 Asian American and Pacific Islander Heritage Month honoree for her work with patients with mental health challenges, and she's truly deserving of this honor. She's always willing to be out in the community helping to educate or do what she can. So very excited for this recognition for her. And then lastly, just want to mention that on May 2nd, We had at the club in Castlewood in Pleasanton, we hosted the annual golf and bocce tournament. Our total proceeds were over $124,000 in support of the purchase of equipment for the hospital's operating rooms and trauma center. Also, make sure everyone has on their calendar October 12th, Saturday, and it will be this year's the 38th annual Top Hat Gala. And then lastly, the foundation is also accepting applications for the Dr. Albert Asali Scholarship, which is awarded annually to a high school senior or college student pursuing higher education in the field of medicine. So just want to give those updates from the foundation, and that ends my report.
Kimberly. Now, we got a couple of action items. Director Wallace.
2 action items. Yeah.
Thank you.
We have a lot.
This is the one.
Yeah. Thank you. Mr. President, I move that the Board of Directors certify and approve the post-retirement employment of Marianne Heitzel to fill a critically needed position for no more than 90 days and not to exceed 160 hours.
Sure.
I just want to say this is one of those, she's a tumor registrar, it's a position of one, and she has retired, but we need her just to help with assistance with the transition to a new person. So.
Director Eaton?
Aye.
Director Wallace?
Aye.
Director Nicholson?
Aye.
Director Yee? And Director Stewart?
Aye.
Passes.
Thank you. Mr. President, I move the staff recommendation, item B.
For the build out of the urgent care clinic, yeah.
Second.
Yeah, this is just something we're very excited to be moving forward with this, and we'll be doing the build out over in Washington Properties, so it will be close by, but we're very excited to be able to once again offer our community urgent care services.
All right, Director Eaton?
Aye.
Director Wallace?
Aye.
Director Nicholson?
Aye.
Director Yee?
Aye.
And Director Stewart?
Aye. What's
Okay,
the
then.
timeline on that again? 2025.
Yeah, it's going to be about a year in terms of build down.
Okay.
Yeah,
We talked about that.
I know. I was just trying to remember too. We have a number of,
I think it was 10 months.
it's 10 minutes. By the time we get it open, yeah.
Any announcements, Kimberly?
No other announcements.
Then move on to a closed session.
Yeah, so if you want to.
We'll now go into a closed session. However, before doing so, I want to let the public know that they have a right to know what reportable action, if any, was taken by the board during the closed session. Normally, the board would make that announcement following the closed session. As we do not know how long the closed session will last, we do not want members of the public waiting indefinitely for the board's report. Therefore, we ask that you contact the district clerk tomorrow. She will be happy to respond to any inquiries about reportable board actions. Our minutes will continue to reflect any reportable actions taken. The board will now adjourn to a closed session.